24 years of vast clinical radiology experience, it's my privilege to welcome Dr. Rajul Rastogi. He's a professor in Tirthankar Mahavir Medical College with 24 years of experience in clinical radiology. And he has authored a number of publications, more than 195 publications in national and international journals. He has more than 90 theses where he has been a co-guide or a guide to both MD and PhD thesis. And he has authored more than 50 chapters in various textbooks, radiology, endocrinology, and anesthesia textbooks. He's had more than 185 presentations or lectures, guest lectures, orations, presentations to his credit, research papers, and he has been awarded a prestigious Dr. V.P. Lakhanpal Gold Medal by the ICRI, Indian College of Radiology. So I would love to hand over the baton to Dr. Rajul, and I urge all of you to note down whatever questions that come in your mind. You can put it in the chat box, and there will be a question answer session after the talk, which is going to be there for 35 minutes. And we would love to invite Dr. Rajul to answer those questions. And a request to all the participants to please keep themselves muted so that there is no disturbance and they can listen to this audio visual treat that they are going to be subjected to. So come on, let's all fasten our seat belts and be ready for a takeoff. Come, Dr. Rajul, welcome aboard
Yeah,
and can start.
thank you, ma'am, for the nice introduction, and welcome all the listeners and viewers. So, as we all know, we are here to have a small discussion of around 40-45 minutes on the role of imaging in diagnosis and treatment of female infertility. I think my screen is visible to all.
Yes.
Yeah, okay.
Yeah, yeah.
So we all know that it has already been long years when the imaging is playing a very important role in the infertility, not only in the diagnosis of the cause, but also how we can help them in treatment. So we'll go a little about the definitions, and then what is the role of different modalities of imaging, and then we'll have some good pictorial views so that I can demonstrate how the radiology is very useful for imaging as well as treatment in female infertility. So, as per the American Society of Reproductive Medicine, the infertility has been defined as the failure to conceive a desired pregnancy after 12 months of unprotected intercourse. But recently, a new definition has also been given, like it has been described as the inability to achieve a successful pregnancy based on the individual medical, sexual, and reproductive history, age, physical findings, diagnostic testing, or any combination of those factors. So, uh, if we look at the statistics, approximately 10% of the married couples are affected with the infertility, and male and females are equally affected by it. So today we'll be talking about female infertility. So it can be broadly categorized into uterine and cervical causes. So there can be a lot of congenital anomalies, infections, focal or tumoral lesions like polyps, leiomyoma, adenomyomas. Then there may be intrauterine scar tissue. There may be problem with the perfusion of the uterine endometrium, and as per the overall the uterus, the alterations in the endometrial thickness and vascularity. Then there may be ovarian causes like follicular and ovulation abnormalities may be there. The most common being the polycystic ovarian syndrome, and we can evaluate the stromal vascularity, and then there is a disease which is quite rampant in these infertile females, that is endometriosis. Among the tubal causes, the main causes are either infections or the obstruction of the tubes affecting its patency. So among the diagnostic armamentarium, the majority of the patients who are infertile, they will be first subject to the ultrasonography, which forms the mainstay of these of the diagnosis, as well as it will help in the treatment that we will see in subsequent slides. So it is usually a transvaginal or an endovaginal ultrasound, which can be coupled with 3D and 4D imaging It can be coupled with color Doppler and sonosalpingography. And recently, the ultrasound contrast agents are being explored specifically in the form of HICO-C. So, what are the various advantages of ultrasound? The ultrasound, we all know that it is available easily at all places. It is cost effective, it is non-invasive, it is radiation free, it takes very less time as compared to if we compare it with magnetic resonance imaging, and can be easily repeatable again and again. But it has got some errors. It is a subjective modality, so the individual experience plays a good role, and it has got a lower field of view. We cannot view the entire pelvis, and the fallopian tubes and broad ligament visualization is suboptimal in ultrasound, specifically if there is gassy bowel loops are there in the pelvis and in patients who are very obese. So obesity is often associated with infertility, so there the ultrasound has got limitations. The gold standard in many cases of evaluation of the female infertility involves the magnetic resonance imaging. So the it helps in outlining the morphology as well as the pelvic orientation of uterus and adnexal structures and their relationship with each other. Again, it is non-invasive and radiation free, and being radiation free is important when we are dealing with females of the reproductive age group. Disadvantages being limited availability, limited experience, and a relatively higher cost as compared to the ultrasound. So it is often difficult to get serial scans during the part of diagnosis or even the treatment. So, usually the X-ray stereosalpingography is not talked about today, but still in some parts of the India, specifically in all developing countries, because it's very cheap, so it is still being used as a procedure to visualize the uterine cavities and establish the tubal patency. But it has a disadvantage of being using the ionizing radiations in the form of X-rays, and is also associated with risk of infection and injury due to its invasive nature. Another thing is the X-ray rooms that where these procedures are performed are usually not free of the infection, so they are not maintaining the asepsis. So that is why again this X-ray HSG is bound to introduce some infection in these patients. So recently, we all know that to avoid these radiation exposures, the ultrasound has gained repute, and it is being used in the form of the sonosalpingography or the hystero contrast sonography. So, what is the role of ultrasound? What does it? What type of information it will provide us? It will help in determining the normal morphology of the uterus and ovaries. It will help in detection of pathological lesions involving tubes, as well as the uterus cervix. It helps in determination of the uterine and ovarian stromal perfusion with color Doppler and power Doppler. It is in determination of endometrial thickness, volume, as well as vascularity. It helps in detecting the abnormalities of follicular maturation and ovulation if we perform the follicular maturation test. It helps in confirming the tubal patency if we can use either sonosalpingography using normal saline, or we can use a stereosalpingography contrast sonography using the ultrasound contrast agents. Then the ultrasound can help in oocyte retrieval and embryo transfer in all IVF procedures, and it also helps in guiding the drainage of pelvic collections and cystic lesions, specifically the simple ovarian cyst and endometriotic cyst through transvaginal route. But as we discussed briefly that it has got a lot of limitations. So the major limitations are it will not be able to delineate the images in the form of surgical orientation, which is very important while the surgeons are planning some procedure. It fails to achieve optimal images in obese and very apprehensive patients. Failure to detect the PID with high accuracy is often a limitation with ultrasonography. Failure to detect the tubal and broad ligament lesions is also a limitation, and it often fails to delineate the small volume ovaries for which we may require the MRI, and often there is interference by gas in the with the pelvic bowel loops. Now, what the magnetic resonance imaging can provide over and above the ultrasound? So like the ultrasound, it will be able to delineate the normal morphology of the uterus and ovaries in all conditions, even if the patient is very obese. Then detection of the normal morphology of the tubes and broad ligament. So broad ligament is well visualized on MRI. Then detection of the pathological lesions, including the tubal lesions. Detection of pituitary causes, which is outside the pelvis, so ultrasound cannot be used in case the patient of hyperprolactinemia has to be evaluated. And predicting the prognosis in cases where the patient is treated conservatively in patients with leiomyoma, adenomyosis, and endometriosis. So, just a brief about the protocol of MRI. While doing the MRI, we should always make sure that there is optimal distension of the urinary bladder. It should not be under distended or over distended, because it will affect the position as well as the shape morphology of the uterus. It will over distended bladder will press upon the uterus, so it will prevent from getting good information. So T2 weighted images, which should include fat suppressed images as well, T1 weighted, and the images should be taken in all the three planes, that is axial, coronal, and sagittal images. Intravenous gadolinium or the intravenous contrast MR contrast images are used in selected cases of female infertility, specifically when the pelvic inflammatory disease is suspected, or there is we need to evaluate the vascularity of leiomyoma or detection of malignancies which are incidental in cases of the adnexal masses. We all know that the limitations of MRI, there are being the high cost, limited availability, and at times these make repeated examination very difficult. MRI also has a longer examination time, so patients who are claustrophobic, so they will not be able to get an optimal scan. It often fails to delineate sub-centimeter uterine lesions if the lesion is too small, and specifically endometrial calcifications where the ultrasound is coarse over. It fails to characterize the endometrioma at certain stages of its evolution. And whenever there is a relative contraindication in patients like patient with cardiac pacemaker, cochlear implants, pelvic implants, etc. So this is just a tabulated form where we can see which modality to be chosen while we are looking for a particular characteristic in a female patient. So if we are looking at uterine morphology and the lesion characterization, the MRI is a gold standard. Again, for ovarian morphology and lesion characterization, MRI is a gold standard. For tubal, broad ligament morphology and lesion characterization, the MRI is gold standard. But for uterine, endometrial, and ovarian perfusion abnormalities, of course, the ultrasound scores over. The tubal patency test is usually performed with ultrasound. However, some research papers are there which show that it can be performed with MRI as well. Follicular and ovulation abnormalities are easily performed, and ultrasound is the gold standard. And for all practically for all guided procedures, ultrasound is really very good, and certain procedures are still being done by MRI at very few centers all over the world. So now coming on to how we start the evaluation of the patient with presenting with female infertility. So whenever the patient comes to us, we are always looking at the uterus and the ovaries, and whenever we are looking at the ovaries, we should never depend on two-dimensional size. We should always consider an ovarian volume, because it helps in producing the measurements which are reproducible and which are comparable. And the three measurements should be taken at three orthogonal planes, so that every time we take the ovarian volume, we are able to know that whether it is increasing or decreasing. So this is very important. Then antral follicular count. So this count is very important when we are evaluating these patients, because it tells us about the ovarian reserve in the infertile patient. So the antral follicular count is usually done at second to fourth day of the cycle, and the third day is usually preferred. And the antral follicular count includes only those follicles which are less than or equal to 10 mm in diameter. So this 10 in diameter should always be the short axis diameter. So here we can see that this is a follicle and we have to take a short axis diameter instead of the long axis diameter. So long axis diameters should not be taken because we are looking at ovoid structures. So the main reproducible diameter is a short axis diameter. So I've already told, whenever the follicular dimensions are done, it should be always a short axis diameter. So enteral follicular count can also be done by a 5D technique. It's an AI tool which is available in all the high-end premium ultrasound scanners. It helps in calculating the number of follicles which are less than 10 in diameter at a particular time of the cycle, but it does not help in uh, telling us the serial. In the serial scans we will not be able to use this particular tool. So it's good for first evaluation, and it can tell us the number. So good for knowing the ovarian reserve. Now, there is one more thing that is not evaluated in patients with the female infertility. It is the ovarian vascularity. So, the ovarian vascularity primarily refers to the ovarian stromal vascularity. We all know that it has been described that whenever there are polycystic ovarian disease, the stroma becomes very echogenic and highly vascular. So that is one advantage of evaluating the ovarian stroma. And the higher vascularity indicates that less amount of the gonadotrophins will be required. Second, the duration or the effect of the gonadotrophins will be short, and a smaller amount of the gonadotrophins will be able to stimulate more number of oocytes. So this ovarian vascularity can help to tailor the amount of gonadotrophins that should be given in a female who is being stimulated for an assisted reproductive techniques. However, this ovarian vascularity is unrelated to the development of ovarian hyperstimulation syndrome, which is seen during the process of the ovarian stimulation. Now, whenever we are selecting a patient for IVF, we should always look at the presence of a secondary oocyte within a follicular cyst. So, whatever we normally see is a follicular cyst, and this presence of this oocyte indicates that this is a mature oocyte, and the results of the IVF are better when the follicular cyst showing sonographically the secondary oocytes is seen. Uh, a cyst that is targeted for the oocyte retrieval should be round. It should not be too large. If it is too large, the secondary oocyte usually gets degenerated because of the high pressure within the follicular cyst. So just the size is not the criteria. One should be able to find out the presence of the secondary oocyte within the follicular cyst. The another criteria of a impending rupture in a follicular cyst is there should be three-fourth of the circumference of the follicle should be having good vascularity. The RI should be less than zero point 0.5, preferably between zero point 0.4 to zero point 0.5, and a PSV of more than 10 centimeters per second. So if these features are seen during the process of the stimulation, so this time can be used to target the injection for introducing a rupture and getting the ART procedure, specifically when we are targeting the intrauterine inseminations or IUIs. Now, once the dominant follicle ruptures on its own, at times it will show the hemorrhage within the corpus luteum cysts, and we can see a ring of fire all around it. So, it is very important that all the patients who are being evaluated for female infertility should be evaluated as a basic scan in the first on the third day of their cycle. And if we are seeing this residual corpus luteum cyst in that cycle, so this cycle is not good for stimulation. because then it will not be able to produce a good effect. This corpus luteum itself will use majority of the gonadotrophin, and this will go waste. So now we know that ultrasound is being used for oocyte retrieval. So this is transvaginal or endovaginal guided probe which is being introduced into a large cyst, and this is a track along which the needle is being introduced, and once the suction is applied, all the follicular fluid is taken out, and the follicle will get collapsed. In fact, if we try to aspirate too much, at times we end up with the hemorrhage within these follicular cysts. So it's often physiological, but we should avoid aspirating the all amount of the fluid. So the suction pressure should be controlled. So now coming on to certain diseases which we know that they are the common causes in the routine practice. So this one of these is polycystic ovarian syndrome. So as a radiologist or as an imaging person, we can't diagnose the syndrome because it's a combination of multiple clinical manifestations, the biochemical tests, and the imaging features. But on imaging, we see that the ovaries are usually bulky. They have got multiple small follicles. The ovaries have thickened walls, so we have to evaluate the tunica albuginea or the walls of the ovaries, and the thickened and vascular stroma. So thickened and vascular stroma will be seen as echogenic stroma, and usually we use a color power Doppler instead of the color Doppler, because here we do not require the direction of the flow. We just require whether how many vessels are present within the stroma. So you ultrasound characteristically reveals round ovaries with or normal or increased volume, and multiple small sub-centimeter follicles, usually less than 10 mm, are arranged at the periphery of the ovaries with no dominant follicle. So this has been characteristically described as a string of pearl appearance. The ovary has got thickened walls and echogenic and vascular stroma. The MRI also will show bulky ovaries. The follicular cysts will be seen as sub-centimeter T2 hyperintense cysts, and the thickened walls will be seen as hypointense walls on T2, and the stroma will also be seen as a hypointense stroma on T2 weighted images. The appearance of ovaries similar to PCOS is sometimes seen in anovulation, medication-induced ovulation, and vaginal agenesis. So we need to take care of all these factors as well, so that we do not misinterpret that this is PCOS. So now this is a ultrasound image of the ovary where we can see multiple small follicles that are arranged at the periphery. All of them are less than 10 mm, so it's string of pearls, and it's a echogenic and a thickened stroma. So this is just a 3D scan showing the same. So we can perceive the echogenic stroma slightly better in this. Now this power Doppler shows that the entire stroma is highly vascular, so which means that this is again supporting our diagnosis of PCO. And in the same patient, when we evaluated the uterine artery, we saw that there is a reverse diastolic flow. So the reverse diastolic flow, the high RI, is very characteristic of infertile females. So this shows that the uterus has got reduced perfusion, and we need to use some agents or the drugs to improve this. So at times the sildenafil is commonly used, and even a low dose aspirin is being used by a lot of the infertility specialists to improve the perfusion of the uterus as well as the endometrium. So this is MR, sagittal T2 weighted MR, where we can see the polycystic ovary. We can see the hypointense the stroma lying in between the follicles. And please note that this wall of the ovary is very thick. Normally, the ovarian walls cannot be well visualized. So once you start visualizing it, it means it is thickened and it is hypointense, indicating its fibrous nature. So it is the thickening of the tunica albuginea here, so indicating that it is a polycystic ovary. So this particular feature has got a management implication, because if this ovarian tunica albuginea is very thick, the infertility specialist will always try to go for ovarian drilling, because until and unless the ovarian drilling is done, so natural rupture of the dominant follicle will not occur on the surface. So in the initial stages, if they are planning for IUI, so then they will like to know whether this tunica albuginea is thickened or not. Now, another common cause of female infertility is endometriosis. This disease most commonly involves the ovaries but can involve all parts of the reproductive tract, including the uterus, tubes, and the broad ligament. Usually, the laparoscopy remains the mainstay of the treatment, diagnosis, staging, and ultrasound is the preferred technique, where a typical endometrioma is defined as a well-defined cystic lesion with homogeneous low-level internal echoes. These low-level internal echoes is because of the presence of the blood or the hemorrhagic products within the endometrioma located in the ovary, and this is often described as a chocolate cyst because the fluid that is aspirated is chocolate brown in color. The presence of multilocularity or the hyperechoic wall foci or nodules are may be indicative of malignancy. So normally, if you see the cholesterol crystals in the form of punctate echogenic foci on ultrasound, so they are very characteristic of the endometriomas. But if they are large and if they are nodular, so we have to keep in mind that at times it may be just a malignancy, a clear cell type, or an endometrioid carcinoma. MRI is more sensitive in detecting the endometrioma as it appears hyperintense on T1 weighted images at a particular stage when the blood is subacute in nature, and hypo to hyperintense on T2 weighted images. The fat suppressed T1 images are very useful in detecting the perineal implant. So we know that endometriosis is a disseminated disease in many patients. So we have to do the whole abdomen rather than just the pelvis in these patients. Involvement of the tubes can also occur in form of hematosalpinx and peritubal adhesions, while that of the uterus may occur in form of adenomyosis. So adhesions may be seen on MR imaging as hypointense strands within the adjacent fat obscuring the two interfaces. So we all know that the MRI is very good at showing the interfaces because of the presence of the intervening fat between the uterus and the rectum, uterus and the urinary bladder. But when these fat planes are lost and there is a presence of hypointense bands in between the two interfaces, or they are ill defined, so we can say that it is the invasive type of the endometriosis. So a posteriorly displaced or a pulled up uterus, presence of kissing ovaries, elevated posterior vaginal fornix, angulated small bowel loops, presence of hydrosalpinx or hematosalpinx, and multilocular fluid collections are indirect indicators of pelvic adhesion. So all these can be a part of the endometriosis. So now coming on to the certain cases. So this is a case of a giant endometrioma of the ovary, and we can see that this is an irregular lesion. It has got low level, it is diffusely and homogeneously low level internal echoes, and there is posterior acoustic enhancement. So radiologically it is very important to identify that this is not solid, this is liquid, by the presence of posterior acoustic enhancement. And although there are a lot of papillary projections into it, so we can see that there is some power Doppler showing vascularity as well. So this was a difficult case. We have kept a differential diagnosis of the mucinous adenoma as well, but ultimately when the patient underwent the aspiration and removal, so it turned out to be an endometrioma. So such cases are really difficult to be differentiated on ultrasound. Even MRI at times may not be able to tell us with 100% confidence. So the aspiration under guidance is the best answer to the problem. Another case where we saw a large endometrioma and multiple septations were there, but in this case, since the MRI was available, we could see that it was hyper intense, and we could see that it was hyperintense on both T2 as well as T1. So we concluded that this was giant endometrium, but we also aspirated it, and ultimately this again turned out to be a chocolate brown fluid. So it was a large chocolate cyst. So you can see that the endometriomas, when very large, they will definitely pose one or the other diagnostic challenge in the form of the presence of septations, thick septations, vascular septations, or the nodules. So the smaller it is, the easier it is, but larger it is a diagnostic challenge. So the aspiration is often the answer to the problem. Now coming on to the uterine and the endometrial thickness measurement. So we should note that whenever we are taking the endometrial thickness measurements, it should be taken in a midline sagittal scan, and the level is, we should always exclude the subendometrial hypoechoic halo. So we have to take the midline, it should be sagittal, and it should be excluding the sub endometrial hypoechoic halo. So it is known as endometrial echo complex thickness because it is including the endometrium of the two sides, anterior as well as posterior. So this is a transfer scan. At times when we are unable to find out where is the actually the endometrium thickness, we can use this, but we cannot calculate the thickness. We cannot manage the patient according to the thickness measured on the transverse images. So now this is one image the of the embryo transfer when we are doing in cases of the infertile females when they are being subjected to the assisted reproductive technique. So the embryo transfer is always done through the transabdominal route. The ultrasound is done through a transabdominal route, and this is inserted through a transvaginal route, and we can see the catheter in the mid cavity. So this is a second image of the same patient where the catheter has gone superiorly, and when we are injecting the fluid containing the blastocyst, so we have to keep the tip of the catheter around 1 centimeters below the superior most margin of the endometrial cavity. This is just to avoid the reflux of this blastocyst containing fluid into the tubes, because if that reflux there and it gets implanted there, so the risk of the ectopic pregnancies will be there. So that is the reason that the IVF is associated with a higher risk of or a higher incidence of ectopic pregnancies, because whatever we are injecting is, even though it is with a very low pressure and a controlled pressure, but again we are doing it with a pressure technique. So this the initial two slides, the embryo transfer was done with a 2D technique, but we can also use a 4D technique with a 3D live, and we can see that the after the fluid is deposited, we can see some dot like appearance. So this is the point where the embryonic blastocyst containing fluid has been deposited, and we can see that it is a few millimeters below the level of the superior most margin of the endometrial cavity, and we can also see the cornua. So this is right at the optimal place which is desirable by all the infertility specialists. So when we are doing the embryo transfer, we have to look at the endometrial receptivity also, because the higher the receptivity of the endometrium, the higher the chances of patient conceiving and the blastocyst getting attached to the endometrium. So what are the good features that can help us? So once we are looking at the uterine artery spectrum, so we it should be similar to what we get during the pregnancies, although it will not be of that high velocity, but this is ideal where we see typical low resistance flow, a good diastolic flow, and there is complete loss of the spectral window. So in this case, we should also see the endometrial flow. So in this case, we can see the vascularity reaching right up to the center of the endometrium. So this is the best endometrium that is desirable when we are looking for the embryo transfer. Although it is said that even if the vascularity is reaching up to the inner two-thirds of the endometrium, so it is considered to be optimal for the embryo transfer. So there are certain diseases that we encounter while we are evaluating these patients. So among these one is cystic endometrial hyperplasia. So we can see number of cysts, tiny cysts. It's a cluster of small cysts lying within a thickened endometrial echo complex. And when we put on the power Doppler, so we can see a lot of flow inside it, indicating the hypervascularity. And this is a 3D image which is showing these small cysts very well. Then in India and developing countries, we all know that the tuberculosis of the endometrium is not uncommon. So we do see a lot of patients with the tubercular endometritis, and the classical features is you will see that the uterus has lost its typical echo pattern. The endometrium also becomes quite ill-defined and hazy, and it is very thin, as well as showing multiple subendometrial as well as endometrial calcification. So when we are doing the grayscale imaging, these echogenic calcifications may not be that much visible, but when you turn to the 3D imaging, so these echogenic foci of calcification stand out. So then coming on to the tubal diseases, the tubes can be destroyed or obstructed, or they can have peritubal adhesions. So hysterolaparoscopy is the single best investigation that may provide complete information about the tubal status, both the morphology and the patency. Hysterosalpingography, which may be X-ray or ultrasound based, can be informative about the tubal patency. MR-based hysterosalpingography has also been described in the literature around 2 decades back, but it has not become popular because of its cost and the lot of other problems associated with it. MR imaging is superior to ultrasound for study of the morphology of the tubes. Dilated fallopian tubes on imaging can appear as fluid-filled, tortuous, retort-shaped, sausage-shaped, C or S-shaped masses. So there are multiple morphological shapes adjacent to the uterus in the pelvis. Presence of partially effaced longitudinal folds inside the masses are specific for the fallopian tube. So whenever we are seeing some longitudinal fluid filled structures in the pelvis, to differentiate them from the bowel loop, so we can use this as partially effaced longitudinal folds. In the bowel loops, the folds will be symmetric on both sides of the wall, whereas it is not there in the cases of the fallopian tubes. So this is a case of hematosalpinx. So where we can see a C-shaped tube which is dilated with homogeneous low-level internal echoes. The uterus is also filled with the similar type of collection, and this was a case of a hematometra with hematosalpinx. And when the MRI was done, again we could see a hyper intense fluid collection both in the uterine cavity as well as that extending into the right tube, causing its dilatation on a fat suppressed T1 weighted axial image. And this sagittal image also shows that the uterine cavity is filled with a hemorrhagic material. Another case where we can see the dilated tube, it's a hydrosalpinx, and we can see a typical retort shaped on a sagittal T2 weighted image. So this is a classical appearance of a retort shape, and these are tortuous tubes which can be seen just adjacent to the uterus. So we see that the bowel loops in this case are quite away from the pelvic structure, so it is easily differentiable from the bowel loops. Now, we can evaluate the tubal spill by the sonosalpingography as well. So here we inject the saline through the tubal, through the intrauterine Foley's catheter, and then we visualize its spill in the peritoneal cavity using the color Doppler. So we all know that the color Doppler is very sensitive to the flowing fluid. So once you put on the color Doppler, it will be seen as a sprinkle. So first we demonstrate that there is no fluid around the ovary, and if the after the injection of the saline we see the fluid, so it means that there is a spill through that tube. So this is a Foley's bulb in the cavity, and we see the fluid around the ovary. So this was a case of a spill. So here we can see the typical sprinkle of colors, which is demonstrating that this tube is showing is patent, and we cannot see any dilated tube on either side. So this is a left side spill, this is a right side spill, and we cannot see. So this image focuses only on the spill, so that is why we cannot see the Foley's as well as the uterus. So this is a case where the after injection of the saline through the Foley's lying in the middle part of the cavity, we see dilatation of the upper part of the uterine cavity with cornual block. So we could not see any spill, no color was there in this case. So this is another case where there was a hydrosalpinx. There is lot of mobile echoes were there, but actually there was once we injected the saline, we could not see any spill around the ovary. At times the tubes are also dilated, and we can see a small sprinkle of colors. So this can be because of the peritubal adhesions causing partial obstruction, and this may be because of the partially patent tubes as well. Now coming on to the pelvic inflammatory disease. Pelvic inflammatory disease is another important cause of female infertility, and it can involve the uterus, the tubes, the ovaries, as well as the broad ligament. It can be seen in the form of tubo-ovarian collections, which can be easily drained and at times can be medically treated. Uterine infections and broad ligament infections are difficult to pick by ultrasounds. Ultrasound and MRI are equally sensitive in detecting tubo-ovarian collections, but MRI is superior in because of its superior soft tissue contrast resolution. Presence of peripheral vascularity of high resistance type in a collection is suggestive of infective and inflammatory mass on color Doppler, whereas presence of a high signal inner rim on T1 weighted images, which enhance on post contrast images, are highly specific for the tubo-ovarian abscesses, which are secondary to the PID. So a collection which is round to ovoid showing peripheral color on color Doppler, high resistance on spectral resistance is specific for the infective and inflammatory masses, and similarly the hyper intense inner rim on T1 weighted images, which enhances on post contrast T1 weighted images, is specific for tubo-ovarian masses on the MRI. MR imaging is superior to ultrasound in revealing infected uterus, that is myometritis, and broad ligament infections, which will appear hyperintense on T2 weighted images. We should keep one thing in mind, that slight hyperintensity of broad ligament can be seen during the menstrual and the immediate post-menstrual phase as a part of the physiological change. So this is an ultrasound image where we can see the thickened fallopian tube. We can see a little fluid, and the wall is very thick. So this was a case of a tubercular salpingitis. In the same patient, we saw that the ovaries are also distorted, and there was some echogenic mass which we suspected because it was not showing any vascularity. The CA125 was also normal, so we suspected that this was a tubercular abscess. The patient was put on ATT, and both these thickened tubes as well as the abscesses disappeared within 3 to 4 months of the treatment. So another patient with PID, where the left sided fallopian tube was not seen, and there was hyperintensity in the broad ligament as well, and some fluid as well, and there were thickened ovaries as well. So polycystic ovaries, PID, and the digestion of the tubes was there in this case. Another case of PID, we can see multiple small bowel loops are present adherent to each other with a hyperintense area in between, and there is a ovary which is attached to this bowel conglomeration. So this was a case of a PID. In another case, we can see lot of hyperintensity in the bilateral broad ligament, especially on the uh, right side, and we can see that this is also there on a fat suppressed image on the coronal star images. Another patient with which shows that the a lot of fluid in the pelvic in the pouch of Douglas, the tube was interrupted. The ovary was seen, but there is too much distance, the uterus was located in the right hemipelvis because the tube was completely digested. Lot of fluid was also noted on the ultrasound, and in the another patient we could see that this uterus myometrium is also quite hyperintense. So this was again a case of the pelvic inflammatory disease involving the uterus, the blood ligament, as well as the tubes. So leiomyoma is infrequent cause of infertility, and theoretically it may interfere with the transportation of sperms or implantation due to the distortion of the uterine contour and its cavity. Endovaginal ultrasound is as sensitive as MR imaging detection of leiomyoma, but MRI is superior to the endovaginal ultrasound in preoperative evaluation of site number and size of leiomyoma, that is often referred to as fibroid mapping, which is commonly used in this era of laparoscopic treatment. A typical leiomyoma will appear as a well-defined hypoechoic to heteroechoic solid lesion with mild to moderate posterior acoustic enhancement, shadowing located in the submucosal, intramural, or subserosal region. The color Doppler will reveal mild to moderate high resistance peripheral vascularity, and this characteristic feature differentiates it from adenomyoma. But in practice, many cases that we diagnose as fibroid, they turn out to be fibroadenomyoma. So we should keep this in mind that in fact true fibroids and adenomyomas and mixed adenomyomas represent one third for each fraction, and leiomyoma is seen as a well-defined focal solid lesion appearing hypointense to myometrium on T2 weighted images because of their calcium as well as fibrous content. So MR imaging is superior in differentiating leiomyoma from adenomyosis. Different types of degeneration can have different appearance on MRI. So if hyalinization is there, so it will appear hypointense on T2 weighted images. If there is edema, which will appear hyperintense on T2 weighted images. If there's cystic degeneration, it will appear hypointense on T1 and hyperintense on T2 without post-contrast enhancement. If there is myxoid degeneration of fibroids, it will be hyperintense on T2 weighted images with delayed post-contrast enhancement. And red degeneration will appear hyperintense dim because of the hemorrhage, and a hypointense and red because of the acute blood products. So leiomyoma after uterine artery embolization appear hyperintense on T1 and homogeneously hypointense on T2 weighted images. So this particular feature is useful when we are monitoring the patients who have undergone uterine artery embolization as a part of the treatment during the female infertility. MR imaging is also useful in predicting the outcome of treatment of leiomyoma following uterine artery embolization and gonadotropin analog therapy, and monitoring the post-treatment changes and recurrence in patients treated with uterine conservative methods of treatment. So if we look at adenomyosis, it is also uncommon, and it causes reduction in uterine and endometrial receptivity that we have studied in the form of the uterine perfusion. So we see enlargement of the uterus. Both transvaginal ultrasound and MR imaging are equally effective in making a diagnosis, but there are certain features on ultrasound that gives a characteristic appearance to the adenomyosis, that is diffuse enlargement. So we call it global enlargement with asymmetry of the anterior and posterior wall. So it has been described in the literature that if the posterior wall measures more than 2.5 centimeters in thickness, consider adenomyosis as the diagnosis. Ill-defined areas of increased and decreased echogenicity. This is because of the hemorrhage within the myometrium, diffusely altered uterine echo pattern, and small myometrial cells. So when the hemorrhage ultimately gets resolved, so it will turn into a myometrial cyst. MR imaging is superior because it can identify these hypointense masses with poorly defined margins as focal or diffuse, symmetric and asymmetric widening of the junctional zone. So this is very specific. It can be symmetric or asymmetric widening of junctional zone greater than 12 mm in the uterus. There are hyperintense foci representing ectopic endometrium. So this is also classical on MRI, and this will be seen on T1 weighted images. Again, as we have already discussed, that MR imaging can be useful in monitoring the treatment of these patients. So coming on to few cases, so this is a sagittal ultrasound image where we can see a large fibroid with a calcification which is lying on the submucosal site. So this was a large fibroid going from the submucosal to the subserosal location, and we can see that is why the patient was having significant pervaginal bleeding. Another case, there was a large subserosal fibroid. So at times 3D views are very useful in showing the location to the surgeon while they are going endoscopy. So in this case, we can see that it is intramural and subserosal, but it is sparing the endometrial cavity. So this is a small hypoechoic fibroid which was lying in the submucosal location. So it is difficult to treat, and at times it's often missed. So we have to look at the endometrium very carefully, because here the only criteria was the displacement which caught our eye, and we were able to find out the cause for the pervaginal bleeding and lack of conception. Another case where we can see a heteroechoic lesion in the anterior wall. It was bulging on the surface, and it was even causing some indentation on the posterior bladder wall. So it was a fibroid. Another case where the patient had a PID, but a small lesion was bulging into the posterior wall. So in this way, we can pick up these small fibroids as well. When the MRI is done, at times the small fibroids in the intramural location will be seen just as hypointense lesions, and they are displacing the endometrial cavity. In this case, a large pedunculated fibroid was seen. So it is very difficult often on ultrasound to demonstrate the pedicle, but MRI is very useful because it is able to show the pedicle of the fibroid. So it helps in planning of the removal of such fibroids. Another case of the uterine adenomyoma. So here we see that the uterus is large. We are not able to define that there is some mass, but there is diffuse enlargement. There is lack of complete echo pattern that should be there. There is lot of vascularity which is not seen with a normal uterus, and when we did the uterine Doppler, the spectrum was almost corresponding to as of the ovulation phase or the pregnancy. So we concluded that this has to be adenomyosis. We talked of the myometrial cysts. These are often seen well, and this is a 3D image which better delineates this, and putting on the power Doppler gives the high vascularity to this uterus, and indicating that this is a adenomyosis. So uterine anomalies are the also the causes of infertility. I'll not be touching this because it's itself a very big topic, but MRI in the coronal and perpendicular planes are diagnostic, and whenever we are doing this imaging, the kidneys should also be evaluated, and the Mullerian anomalies are now being classified as per 2021 American Society of Reproductive Medicine. The 3D ultrasound and MR imaging help in identifying anomalies, but the latter is preferred because whenever the reconstructive procedures are being planned, so MR scores over the ultrasound. So there are few cases. So this is a case of a uterus subseptus. So we see two uterine cavities in the superior part of the cavity, but this is almost corresponding to the myometrium. So it was a myometrial or a muscular septum was there. So this is just a 3D image in a gray scale and a 3D image in a color scale. And here also we can see a small septum lying within the uterine cavity. When we did the sonosalpingography in this case, we could see that there is a septum which is similar in echo pattern to the myometrium, and there were two cavities. So it was again a case of the confirmed that it was a uterine subseptus. Similarly, when this patient was subjected to the MR, so we could see the subseptic uterus. So this is the rare case where we could not see the ovary, as well as we could not see some any indication that the cornea is present. So we said that the we could not see the ovary as well as the adnexa on the left side, and on laparoscopy they found that there was a complete absence of the left tube and the adnexa, and there was a polycystic ovary on the right side. So coming on to the last few slides. So as we discussed, if the patient is having hyperprolactinemia, which is often a part of the hormonal workup in these for infertile females. So if the prolactin levels are too high, so the pituitary imaging is often resorted to, and if there is a microadenoma less than 10 mm in size, so it is very difficult to pick up on routine imaging. So we have to do the dynamic MR contrast imaging, and these are usually hypointense to the normal pituitary. The change in pituitary contour, that is convexity of its margins, deviation of the pituitary stalk, are the indirect signs. The dynamic post-contrast MR imaging of the pituitary is the preferred technique for detecting the microadenomas. This technique reveals strong enhancement of the normal pituitary and its stalk in the early phase, in contrast to the faint enhancement of the microadenoma. So microadenoma will be seen as a small non-enhancing or a hypointense lesion within the enhancing pituitary when a dynamic post-contrast imaging is done. Macroadenomas are very easy to detect, and they can be seen to invade the other structures like optic chiasm, cavernous sinus, and a bony cella. So this is a sagittal post-contrast T1 weighted image, which is showing a large pituitary macroadenoma in a patient with infertility, and it is causing the enlargement of the cella as well, and we could see that it's an enhancing tumor. So removal of this macroadenoma becomes mandatory when they are treating the such patients. So the take home message is ultrasound should be the first investigation of choice in all patients presenting with infertility, as it is highly accurate in detecting polycystic ovaries, leiomyoma, endometriosis, adenomyosis, endometrial thickening, and uterine and ovarian anomalies. Color Doppler ultrasound is a sensitive imaging technique to determine the state of uterine perfusion, very important while we are looking at uterine receptivity. An important factor in female infertility, also useful while utilizing in vitro methods of fertilization. MRI should be used as a second line tool in patients with clinical disease and normal USG. When the USG findings are suggestive but not characteristic or classical, when ultrasound findings are atypical or multiple, and when a particular question cannot be answered on the ultrasound. MR imaging serves as a useful adjunct to diagnostic hysterolaparoscopy, especially in patients with tubal disease, including peritubal and pelvic adhesions, as well as endometriosis. MR imaging is highly accurate in non-invasive diagnosis of uterine anomalies, adenomyosis, leiomyoma, and endometriosis. MR imaging is useful in predicting the outcome of patients who are being treated conservatively for adenomyosis, leiomyoma, and endometriosis, and may help in better treatment planning. So I've tried to cover as much as possible. Thank you very much for your patient listening.
Thank you, Dr. Rajul. That was really illuminating and quite an exhaustive talk. You covered practically every case. You showed us a lot of therapeutic interventions also possible. And I'm sure the audience will also be having quite a lot of questions on this regard. For paucity of time, I think I hand over to Dr. Vinita Saran. I have a couple of questions, and I think Dr. Vinita will be conducting a question answer session jointly with me, and Dr. Rajul will be happy to answer them.
Yeah, please.
Uh, Shall I? mm, Shall I
Yeah.
start the first question, Dr. Vinita?
Yeah. I think we will, since we are already past 8 o'clock, so
Yeah.
we'll take just one or two questions, and then I'm sure Dr. Rajul will be happy to answer questions if people will reach out to him directly
Yes,
Yeah.
yes.
after the program. Yes.
Uh-huh. So, just a short question. Regarding oocyte retrieval technique, would you like to illustrate what is your experience? When do you do it? What is the needle you use? And also for the benefit of the residents out here, if they are interested in any specific program for training program, like would you suggest any training where they are specifically trained on this aspect, any certificate or fellowship program on this?
So, a lot of fellowship programs are there for infertility diagnosis and oocyte retrieval and ovulation induction methods, but they are mainly targeted for infertility specialists. But as a radiologist, what I can say is we are all trained for doing the transvaginal procedures using the guides. So, if we are able to uh, aspirate the cysts under the TVS guidance, so the oocyte retrieval is not a problem. So when I started, I was confident that I would be able to do it. The only thing is you have to have some coordination between the paddle and your hand. That's all. Because as a normal diagnostic people, we are not using the paddles so often. So here there is additional paddle which you are using with the foot switch, and you are using the suction using the paddle. Otherwise, the rest of the technique remains the same. It is a TVS probe. It is fixed with a guide. The track is there. You are just focusing the lesion and you are inserting the needle. So this is all decided already by an infertility specialist, because they know what is going on regularly. So every institution has got their specific ways of handling these IVF procedures. But for radiologists who are regularly focusing and who are all regularly draining the cysts or the collections through a transvaginal route, it does not require any additional training.
That's nice. And how many oocytes do you take out, aspirate all of them in one go, or?
Yeah, so because this procedure is usually done under sedation, and we keep all the aseptic lab with everything ready, and usually we do not require GA, and we aspirate as many follicular cysts as possible, and until and unless the cyst is lying very close to the colon, because while you are creating a suction force, so you should not be able to go outside the follicular cyst wall. Otherwise that cyst fluid will go into the ovaries also, and we have to make sure that the cyst should not cross the ovarian boundary on the other side. Otherwise your suction will pull the omentum or the bowel loop. So it is expertise. So you do it regularly and you get that expertise. It's not very difficult to do it. You start with two or three cysts in one ovary, then two or three cysts in the another ovary. The problem arises if the ovary is too mobile. So in those cases, what we have tried is we put some intra-abdominal pressure. We ask the OT or the IVF lab assistant to put the pressure from the abdomen on that side of the hemipelvis, and then the ovary will get fixed. And then once you insert into the suction catheter into one of the follicular cyst, you don't take out the needle from the ovary. You just go through the ovarian stroma itself, so that you don't lose the oocytes. Otherwise, if the fluid leaks into the peritoneal cavity, we might lose the oocytes. So we try to retrieve the fluid from majority of the cysts which are more than 16-17 mm in diameter, short axis diameter.
Thank you.
Okay, so I also one question. Is 2D or 3D ultrasound better in predicting the endometrial receptivity?
See, when we are talking of receptivity, we have to talk about the power Doppler. So there have been few studies where they have tried to quantify with 3D, but there is no additional advantage. It will take a lot of time. So if one has got a premium ultrasound scanner with AI features which can calculate a lot of information within few seconds, then it's fine. Otherwise, in experienced hands, you do not require a 3D color flow. 2D is more than enough.
Okay. Okay. Thank you for your reply. If it is okay, maybe we can stop here the question and answer session. And I would request the audience, if they have any questions or any queries, you can reach out to Dr. Rajul Rastogi. He's at Mahavir Tirthankar University. So you can reach out to him. We can also share his number. I hope we have the permission to share your email and
Yeah, you
number.
can share
So
the email and WhatsApp
yeah,
number.
people can, yeah. Okay, thank you very much, Dr. Rajul, for a very, very informative talk. And thank you, Dr. Akhila, for being the chairperson. You added value to the program. Thank you so much to both of you. And now I would invite Dr. Sushil Jain. He is the Honorary Secretary of our GAPIO, and he is the Medical Superintendent at Indore Apollo Hospital. Dr. Jain.
Yeah, thank you, Dr. Vinita. I'm sorry I'm not able to put on my video, but thank you, Dr. Rajul, for the wonderful session. I was listening throughout the session. It was really interesting. Thank you,
very
Dr. Anju, for the welcome remarks, Dr. Akhila for moderating this session, and of course, Dr. Vinita, as always, being instrumental in conducting this session. So thank you, everyone. I thank the audience to who has patiently listened to this, and I'm sure that they will be definitely benefited with this session. I also like to thank Jiten from the GAPIO office who coordinates everything, and the IT team for making this session virtually possible. So thank you, everyone, and good night. Thanks.
Yeah, thank you. Thank you, everyone, for participating.
Thank you. Thank you.